Hello, it's Dmitry again. Today we're back in the Gastroenterology section for Mehlman Medical Internal Medicine PDF. So this is going to be a part 2 for the Gastroenterology section. We're on page 116. We're going to begin with the gastritis causes plus high yield points. Now for reference, this section, this chapter is going to begin, we're doing today, we're starting off on page 116. We'll be trying to wrap up on page 148. I don't know if we're going to go that far for this entire video. If I don't, then I'll have to make a third video to wrap it up the section. So regardless, let's begin at gastritis causes plus high yield points. Acute gastritis will present as irritation leading to bleeding of gastric mucosa, that is to say from NSAIDs, for example. Chronic gastritis will be an atrophy or autoimmune destruction of the mucosa associated with the decrease in mucosal thickness, a decrease in hydrochloric acid production, achlorhydria, increase in gastrin production, and enterochromaffin-like cell hyperplasia. Increase in histamine production to compensate for the decrease in acid. NBME will give you this constellation of findings and then just simply have a chronic gastritis as the answer, with acute gastritis not even listed. It's not hard, but I've seen students miss this a lot. So again, it says right here, NBME will give you an constellation findings and just simply have chronic gastritis as the answer. Okay. So with acute gastritis not even listed, it's hard. It's not hard, but I've seen students miss it. Okay, so just be, I guess, kind of aware of how they might phrase it, okay? H. pylori causes what is referred to as type B gastritis, which is inflammation tending to affect the antrum of the stomach, can lead to pyloric channel ulcers and plus gastric outlet obstruction. This will present on 2 CK forms as a succusion splash. Pernicious anemia. So pernicious anemia causes what is referred to as type A gastritis, which affects mostly the fundus in the body of the stomach. The autoimmune antibody-mediated destruction of parietal cells. Sometimes antibodies can be against intrinsic factor. Ultra-high yield cause of B12 deficiency, increased MCV plus hypersegmented neutrophils plus or minus neuropathy on USMLE. Associated with other autoimmune diseases, like for example vitiligo. So if they give you an increased MCV in a patient with, for example, type 1 diabetes, you should think autoimmune diseases go together. So if the patient has one autoimmune disease, he or she has an increased propensity for others. Don't worry about the strict HLA associations here. What about NSAIDs? Answer on the USMLE for GI bleeding is someone asking, for example, a indomethacin or naproxen causes type A gastritis affecting the fundus or body. USMLE doesn't specifically care, but you should basically be like H. pylori causes antral gastritis, whereas others like NSAIDs and pernicious anemia are the fundus and body of the stomach. Prostaglandins are necessary for stimulation of gastric alkaline mucus production and maintenance of the gastric lining. They're used for cytoprotection, right? NSAIDs lead to a decrease in prostaglandin production, leading to a disruption of the gastric lining. This can lead to both gastritis, inflammation, and ulcers. As mentioned above, for ulcers, misoprostol can be used in these patients following a PPI, and that was supposed to be like a, I want to go back to that briefly if I can. Yeah, misoprostol is supposed to be a PGE1 analog, hence why it's useful in this context. So, gastric cancer points. Perpetuated over the years as an intestinal versus diffuse types, USMLE doesn't care. What you need to know is that histo will show a signet ring cells that contain mucin, and that you don't need to know the histo for this either. Grossly can cause linitis plastica, which is a leather bottle appearance to the stomach. Gastric metastases can spread hematogenously to the ovaries. These will show up as bilateral ovarian lesions that show, you guessed it, signet ring cells that contain mucin. Increased incidence of gastric cancer in Japan due to the increase in nitrosamine/smoked foods. Multoma, is a B-cell lymphoma that can caused by H. pylori. This does not have signet ring cells. Acanthosis nigricans can be associated with gastric cancer, even though most of the time it just means insulin resistance. Virchow node, or Troisier sign, is how I would assume you would pronounce it. If I actually knew French, I'd probably have a better understanding what they're talking about. Leads to a palpable supraclavicular lymph node that can reflect visceral malignancy, especially gastric cancer. But that's Virchow node stuff. Again, the only real thing you need to know when it talks about the distinction between the different kinds of gastric cancer, again, is the whole signet ring cells that contain mucin. So for intestinal versus diffuse, they don't care. What you need to know is the histo will show signet ring cells. So if you have the gastric cancer, you should see signet ring cells. And obviously it would be useful to know how you can get gastric cancer in the first place, of course, which is what these other points are there for. Hyperbilirubinemia. Unconjugated indirect. Bilirubin is produced from breakdown of heme from RBCs at the spleen. It will initially be unconjugated in this form, where it merely leaves the spleen non-covalently bound to albumin and is not water-soluble. That is to say, it won't show up in the urine. Unconjugated bilirubin is aka indirect bilirubin. In the setting of hemolysis or increased RBC turnover, that is to say sickle cell, hereditary spherocytosis, blood given during surgery, where we have increased RBC breakdown, we get an increase in indirect bilirubin. Once it arrives at the liver, it is taken up by the liver and conjugated to glucuronide, making it water-soluble. Conjugated bilirubin is aka direct bilirubin. If there's, that's the grammar that they use, but that's not grammatically correct. If there's a problem with uptake at the liver, that is to say, for example, acute hepatitis, or there is a deficient conjugation enzyme like Joubert syndrome or Crigler-Najjar syndrome, indirect bilirubin also goes up. Hemolysis or increase in RBC turnover can cause direct bilirubin to go up sometimes as well, but the shift will be more toward indirect being increased. The indirect will be higher, yeah. I point this out because students often get confused by this, but if we have increased indirect bilirubin going into the liver, then this means that the increased direct bilirubin going out. I mean, yeah, but more of the indirect in an acute situation. A 2CK NBME question gives 9 packs of RBCs given during pregnancy. Days later, total bilirubin is 5.0 and indirect bilirubin is 2.3. The answer is overproduction of bilirubin. In regard to neonatal labs, first month of life, I should note that hematocrit percent can be in the 50s. NR, normal range would be 45 to 61. In adults, normal range is 40 to 50. In 2CK, for instance, it will often show hematocrit as 56% in a newborn, and that the student is like, wow, that's high. Where they think there's neonatal polycythemia or some other pathology, but it's actually normal. Unconjugated jaundice can occur in neonates because of the increase in RBC turnover, where the fetal hemoglobin is replaced with an adult hemoglobin type. Or hemoglobin type A, I should say. Because there's also, whatever. I think that is called adult hemoglobin. There's HbF, HbA, HbS, which is the sickle cell type. So, look, fact check me on that if you want to. Conjugated or direct? Yeah, but that is adult hemoglobin adult type. So conjugated or direct bilirubin. Direct bilirubin, since it is water-soluble, shows up in the urine. It will also be secreted into the bile. Therefore, if we have a bile duct obstruction, we get an elevated direct bilirubin. ALP also goes up in bile duct obstruction because it is secreted by the bile duct epithelium. This means that the increase in ALP plus the increase in direct bilirubin is very buzzy for bile duct obstruction. If ALP is high but direct bilirubin is not high, this can be due to things like bone fractures or Paget disease. GGT will also go up with the bile duct obstruction since it also secreted by the bile duct epithelium, but USMLE actually rarely mentions this one. What they want to know is GGT spikes with acute alcohol consumption / binge drinking. In the event of bile duct obstruction, not only will ALP and direct bilirubin go up, but the urine becomes darker from increase in direct bilirubin in it. and urobilin, which comes from direct bilirubin, but USMLE doesn't assess this. In addition, stools become lighter/pale, aka alcoholic stools, since there is a decrease in direct bilirubin making it to the intestines, which means that the decrease in stercobilin production, pigmentation in stool, in other words, dark urine plus pale stools, is buzzy for bile duct obstruction, and in the same way the increase in ALP and increase in direct bilirubin is. Remember, dark urine plus pale stools equals bile duct obstruction, as does increased ALP and increase in direct bilirubin would be indicative of that. Acute hepatitis can also cause an increase in direct bilirubin due to the decrease in secretion in the bile, in addition to the increase in the indirect. But this makes sense since it is literally an intrahepatic pathology. Highest yield cause of increased direct bilirubin on USMLE is the biliary atresia in neonates, discussed later. This is all over the place, whereas Kriegler-Najar significantly increases the indirect bilirubin in neonates is non-existent. Dubin-Johnson and Rotor syndromes are virtually non-existent on USMLE, but cause increase in direct bilirubin in the adults due to a decrease in the bile excretory pumps at the liver. Students get hysterical about these because they sound weird, but they're low yield. Dubin-Johnson is asked once on a new 2CK NBME form, but apart from that, it's low yield. And I think Dubin-Johnson syndrome is a black liver syndrome. Cholangitis, inflammation of the bile ducts, choledocholithiasis, stone in biliary tree, choledochal cyst, head of the pancreas cancer, impingement on common bile duct, and cholangiocarcinoma bile duct cancer are all high yield because of the bile duct obstruction. I discussed all of this in the conditions and of these conditions below in detail. Bilirubin uptake/secretion diseases. We have Gilbert disease, and you think it's pronounced Gilbert. It's not. It's like the French. It's not Target. It's Target. Oh my gosh. I mean, I don't know what's going on, man. It's Gilbert disease. Pronounced Gilbert, not Gilbert. Gastroenterologists I met once tripped out over med students pronouncing this wrong. They're pronouncing it in a way an English person would pronounce it, not some guy from Toulouse would pronounce it, I guess. Partial deficiency of bilirubin uptake enzyme at the liver, UDP glucuronyl transferase, presents as isolated increase in indirect bilirubin with yellow eyes in young adult with stress factors such as studying for exams or recent surgery/trauma. The patient will otherwise be completely healthy. No treatment is necessary. Kriegler-Najar, near absence of UDP glucuronyl transferase causing significant increase in indirect bilirubin in neonate, non-existent yieldness, but students ask about this. Dubin-Johnson, decrease in excretion of bilirubin into bile at the liver due to the decrease in secretory pumps, causes an increase in direct bilirubin in otherwise healthy adult. Can cause a black liver in theory. Yep, I know my stuff on that. That's all I remember. That's all I remember, though. Asked once on the new 2CK NBME, apart from that, non-existent on USMLE. Rotor syndrome, same as Dubin-Johnson, but no black liver. That's no fun, Where's the fun in that? It's the same thing as this, but there's no fun, color change at all. It's like, oh, okay. Rotor syndrome, non-existent diagnosis in USMLE. Students get maniacal over this supposedly not having a black liver, whereas Dubin-Johnson has a black liver. Rotor, that's the one there has no black liver, but Dubin-Johnson does. Relax, take 2 steps back, chill out for 2 seconds. USMLE does not care. We're trying to keep this family friendly, Biliary atresia, one of the highest yield PEDS diagnoses. Answer on the USMLE for a significant increase in direct bilirubin in a kid under the age of 6 weeks. Caused by a lack of development of the intrahepatic bile ductules and biliary tree. Ultrasound will be done first, but USMLE wants liver biopsy to confirm the diagnosis. Kasai procedure is done to treat, followed by liver transplant if unsuccessful. Primary biliary cirrhosis, inflammation of the bile ducts within the liver leading to the destruction. Answer in a woman Answer: in a woman 20s to 50s who has generalized pruritus, elevated serum cholesterol, increased ALP, and increased direct bilirubin. We're talking about, so again, primary biliary cirrhosis. USMLE loves to mention that the history of autoimmune disease in a patient or family member, because of autoimmune diseases go together, so they'll say that she has type 1 diabetes, lupus, or vitiligo, or her brother has rheumatoid arthritis, etc. They can mention that a stone is present in the gallbladder or on ultrasound, which might get some students to real emotional/confused, but it makes sense since the patient has elevated cholesterol. It is just a distractor point and doesn't really relate to the actual diagnosis at hand, which is, again, primary biliary cirrhosis. Diagnosis of the antimitochondrial antibodies as first step, followed by liver biopsy to confirm. Initial treatment would be ursodeoxycholic acid, or ursodiol. New NBME materials ask a couple of questions on fat-soluble vitamin malabsorption for PBC deficiency, deficiency of the A and D on NBME for each question respectively, with no info supporting these presentations. They just ask for hypothetical vitamin deficiency. In theory, there would be a primary biliary obstruction where the decrease in bile entering the small bowel merely means a decrease in fat metabolism. This is nothing special to PBC, but I mention it because it's asked twice. Again, PBC referring to primary biliary cirrhosis. And they're saying fat malabsorption is more than just A and D. You would have an A, D, E, and K deficiency. ADEK deficiency, A, D, E, K. Those are the vitamins you would have issues with if you're not getting fat absorption, for reference. Now, of course, vitamin A and vitamin D are pretty relevant, but E and K are also something you should be aware of. Autoimmune hepatitis. Young adults with an increase in LFTs who has a positive anti-smooth muscle antibodies. High-yield hepatobiliary conditions. Pancreatic cancer. Head of the pancreas cancer impinges on common bile duct, resulting in obstructive jaundice, increase in ALP plus increase in direct bilirubin, in smoker with weight loss, or in patient who had a gallbladder taken out years ago, so it clearly can't be due to the stone in common bile duct. Patient will not be febrile, can have a dull abdominal pain. Courvoisier sign, so that's how I would assume you pronounce it, Courvoisier, because it's French. But Courvoisier sign is a painless, palpable gallbladder in an afebrile patient who was jaundiced. This is a pancreatic cancer until proven otherwise and is past level. Pancreatic enzymes are normal in pancreatic cancer. Well, that's interesting. USMLE wants the CT of the abdomen to diagnose. CT of the abdomen for diagnosis. Whipple procedure is done to remove the head of the pancreas if the cancer is isolated to the tail. Distal pancreatectomy is the answer. Patient with a pancreatectomy need pancreatic enzyme supplementation. The exam can write this as a pancreolipase. Cholangiocarcinoma. Bile duct cancer. Answer on USMLE if the vignette sounds like pancreatic cancer, but they tell you in the last line CT is negative. So if the CT is negative for pancreatic cancer, then it's going to be cholangiocarcinoma, which is bile duct cancer. Answer is ERCP as the next best step. ERCP. Let me look that up briefly right now. ERCP, pancreatic. ERCP means, what does that mean? Endoscopic retrograde cholangiopancreatography procedure. So he just assumed I'm supposed to know what that is. Yeah, you know, the endoscopic retrograde cholangiopancreatography procedure, don't you know? It's like, no, I don't. I don't know what that acronym meant. Anyway, as the next best step, smoking is a risk factor, same as pancreatic cancer. Can be caused by Clonorchis sinensis, which is a trematode. Okay. What about cholelithiasis? This is a stone of the gallbladder. Remember, lith, or like a cholecystite. What's it called? Lith means stone, of course. Why is the gallbladder called the cholecyst? Because it's a cyst refers to almost like its own little bladder, right? It's a little vessel thing. Like, think what a cyst is otherwise. Like, people think a cyst is like a sort of pathological thing that's undesirable, not typical, but like it's sort of this outpouching thing that you have, and that's why it's called a bladder as well. It's called the gallbladder. When you think about bladder, we think about the urinary bladder, but fish have a bladder that helps them float, for example. Referring to like an outpouching, and that's why it's called a gallbladder. That's why it's called a cholecyst. The cyst is like a sort of space, which is supposed to be holding what? The well, yeah, you get the point. It's supposed to be holding the bile and so forth. Anyway, but this is called cholelithiasis. We think of it as this is a stone in the gallbladder. Stones in the gallbladder present with biliary colic, which is acute onset waxing/waning spasm-like pain in the epigastrium or right upper quadrant. Pain is due to cholecystokinin causing gallbladder contractions, where a stone within the gallbladder transiently obstructs flow of bile into the cystic duct. They ask this on the 2CK as well, but the patient will have biliary colic and answer is obstruction of the cystic duct opening by stone. Not dramatic. Classic demographic is 40, 4Fs, fat, 40s, female, fertile. So they're overweight, they're 40 and older, they're female, and they've had lots of kids. For cholesterol stones, right? These are cholesterol stones. This is because the estrogen upregulates HMG-CoA reductase, causing an increase in cholesterol synthesis and secretion in the bile. NBME will give you the standard vignette for 4Fs, and then the answer will just be increased secretion of cholesterol into bile. Another NBME question will give a vignette of cholelithiasis, and rather than just asking for the diagnosis, they will ask what the patient most likely has. The answer would be a lithogenic bile. Slightly awkward, but means promoting the formation of stones. Elevated cholesterol stones in pregnancy, not just due to estrogen effect, but also because of progesterone slows biliary peristalsis, biliary sludging. Tangentially, progesterone also slows the ureteral peristalsis, which is why there's an increased risk for pyelonephritis, as discussed in the high-yield renal PDF. Cholesterol stones, most common, but pigment calcium bilirubinate stones are exceedingly high yield for hereditary spherocytosis in sickle cell due to the increase in RBC turnover. USMLE wants you to know that the splenectomy is a treatment for hereditary spherocytosis to decrease the incidence of cholelithiasis. Sometimes a vignette wants cholecystectomy or plus splenectomy as combined treatment, or if they say that this was in the patient's history in patients with low hemoglobin, you know the disease is hereditary spherocytosis. You know that the diagnosis is hereditary spherocytosis, autosomal dominant. Infections can also sometimes cause pigment stones, but low yield. Diagnosed with abdominal ultrasound. Ursodeoxycholic acid, ursodiol, decreases the secretion of cholesterol into the bile. USMLE just wants you to know that this mechanism of action, plus that it can be used in patients with asymptomatic cholelithiasis, those with declining cholecystectomy, and in pregnancy. What about cholecystitis? Remember, cholecyst is a word we mean gallbladder, so really it means gallbladder-itis. Yeah, cholelithiasis plus fever. Vignette will sound exactly like cholelithiasis, but we have to add a fever on top of it. We now just call it cholecystitis. Virtually always due to obstruction by a stone plus infection as a result. Diagnosed with abdominal ultrasound showing the stones. If the ultrasound is negative, do a HIDA scan, an HIDA scan. Treatment would be cholecystectomy. Emphysematous cholecystitis is air visualized within the biliary wall. USMLE wants Clostridium perfringens as the organism can cause gas gangrene anywhere, in this case. Chronic cholecystitis is calcification of the gallbladder, aka chronic calculous cholecystitis or porcelain gallbladder. It is due to repeated bouts of acute cholecystitis. ALP and bilirubin will not be increased in 19 out of 20 questions. Okay, that's interesting. Will not be increased. This is because the inflammation of the gallbladder does not mean we have any form of common bile duct obstruction. However, there is one nonsense question on a 2CK NBME where the 4 of the answers are widely wrong, while with correct answer being cholecystitis in the setting of high ALP plus direct bilirubin. Since cholecystitis is caused by stones virtually always, the implication is patients can occasionally have concurrent cholelithiasis. Cholelithiasis. Stone anywhere within the biliary tree. Don't confuse with cholelithiasis. Obstructive jaundice, increase in ALP plus direct bilirubin in patients who has a history of cholelithiasis or history of cholecystectomy performed within the past week. Regarding the latter, the question can say the patient had cholecystectomy performed a week ago, plus intraoperative cholangiography was not performed. The implication is bile duct patency is supposed to be visualized during the cholecystectomy to ensure there isn't a stone retained within the biliary tree. However, the question need not to say intraoperative cholangiography was not performed. This makes the question pass level. USMLE wants abdominal ultrasound followed by an ERCP as the answer. The ERCP tends to show up as what they want, but there is a question floating around somewhere that asks for the ultrasound first, so know that sequence. As I talked about earlier, I've never seen MRCP as a correct answer. Being able to discern cholelithiasis from the pancreatic cancer is vital for USMLE. If they give you obstructive jaundice, but say that the patient is a heavy smoker with weight loss or hasn't had a gallbladder for 25 years, you know it's the head of the pancreas cancer, not cholelithiasis. And then, once again, it sounds like pancreatic cancer, but in the CT is negative. That means it's cholangiocarcinoma, and we do the ERCP, which again is the endoscopic retrograde cholangiopancreatography. Again, for cholelithiasis, we want to do, it says wants abdominal ultrasound followed by ERCP. What about gallstone pancreatitis? Gallstone pancreatitis is a type of cholelithiasis in which the stone has descended in distally enough the common bile, in the common bile duct that is now obstructs the hepatopancreatic ampulla. This results in the backflow of pancreatic enzymes to the pancreas, causing damage and acute pancreatitis. USMLE wants hepatopancreatic ampulla as correct over the common bile duct. It wants hepatopancreatic ampulla rather than the common bile duct. If they ask you to choose the location of the obstruction, slightly odd since the stone is still in the common bile duct, but hepatopancreatic ampulla blockage is why we have the pancreatitis. The vignette will give obstructive jaundice, but also high pancreatic enzymes. In other words, the Q will give you an increase in ALP, increased direct bilirubin, and an increase in amylase lipase. I repeat that pancreatic cancer will never have elevated enzymes on USMLE. So this is a pass level means to distinguish. A new 2CK NBME has CT of the abdomen as done first prior to ERCP. This is because even though we have a stone requiring removal from the biliary tree, CT of the abdomen first looks for the pancreatic fluid collection. So CT would still be first for gallstone pancreatitis. Cholangitis. Cholangitis, inflammation of the bile ducts. You must know that the Charcot triad for cholangitis, which is 1, fever, 2, jaundice, 3, abdominal pain. We classically learn this as right upper quadrant epigastric pain, but I can tell you that USMLE doesn't care and will just say abdominal pain. I've had students get cholangitis questions wrong because they're like, I thought this was the right upper quadrant pain. And I'm like, yeah, I agree, but USMLE doesn't care. We'll present 3 ways on USMLE. 2/5 of questions will be ascending cholangitis, which is an infection from the ascension of the bowel flora, like E. coli or Bacteroides, up the common bile duct. 2/5 of the questions will be primary sclerosing cholangitis, which is the inflammation of the bile ducts in the setting of IBD, always due to ulcerative colitis on USMLE, but can rarely be due to Crohn's in real life. P-onca can be positive, and there can be a beaded appearance of the common bile duct on cholangiogram. On 2CK NBME 10, there is a Q on primary sclerosing cholangitis, where the patient is afebrile, rare, i.e. we don't have a full Charcot triad, but they say the patient has a UC, ulcerative colitis plus obstructive jaundice. ERCP shows a narrowing of the bile ducts. To answer is evidently PSC, which is a primary was that PSC in this case? I might have to get back to him. I'll pass on that one right now. So the answer is evidently PSC. 1/5 of the questions will just give you a patient with a history of cholelithiasis, where the implication is the stone has descended to causing a cholelithiasis, which in turn led to obstruction plus inflammation of the common bile duct. USMLE wants antibiotics plus ERCP to diagnose and treat. Biliary drainage by ERCP decreases morbidity and mortality. So let's look at PSC, primary sclerosing cholangitis. Primary sclerosing cholangitis. Okay, I just saw it. I'm going to go take a brief break. I'm at about 30 minutes right now. Okay, we're back. Let's talk about acute pancreatitis. Increase in amylase and or lipase in patient who has abdominal pain. Pain need not radiate to the back. Alcoholism and stones are two biggest risk factors. Hyperlipidemia and hypercalcemia can also occasionally be causes. Can be caused by drugs like Didanosine is HIV NRTI, exenatide is a GLP-1 analog for diabetes. Scorpion sting and mumps also causes are non-existent on USMLE. So don't really worry about those two. Can be caused by choledocholithiasis, gallstone pancreatitis, increase in pancreatic enzymes and setting of the increase in ALP and increase in direct bilirubin. Results in enzymatic fat necrosis. You don't need to memorize Ranson criteria, elaborate criteria for surgery to determine prognosis in pancreatitis. What you need to know are two main points. One, decrease in serum calcium and increase in glucose are bad prognostic indicators. In fact, I'd say low calcium is quite possibly the highest yield variable on USMLE for pancreatitis. There are many long, vague pancreatitis questions out there where they'll mention decrease in calcium in the stem and you're like, boom, pancreatitis. The degree of lipase and or amylase elevation does not correlate with prognosis. In other words, if amylase is 1200 versus 10,000, it's not important for patient outcome. 3, the rest of the Ranson criteria is more surgery rotation. Okay, I'm not going to read that. Stuff, info, otherwise nonsense for USMLE. It's to my observation, MBME questions will sometimes list high amylase without mentioning lipase for whatever reason. Lipase is more specific for pancreatitis, but it's what MBME sometimes does, so don't be confused. High yield initial management for 2CK is a triad. 1, NPO, nil per os, or nothing by mouth. This can be written as simply bowel rest as MBME answer. 2, nasogastric tube decompression. 3, IV fluids with normal saline. This triad is not specific for pancreatitis and can be done for a number of GI-related conditions, including cholangitis and stones, but it just tends to be tested a lot for pancreatitis. So again, bowel rest, nasogastric tube decompression, IV fluids with normal saline. After this initial triad, CT scan of the abdomen is the answer on NBME as the next best step to look for any degree of fluid collection. If a pancreatic pseudocyst is present, NBME answer is to drain this by ERCP. Again, ERCP refers to the endoscopic retrograde cholangiopancreatography. It's to my observation on USMLE doesn't assess antibiotics as part of the pancreatitis treatment, but apparently the carbapenems like imipenem have fantastic penetration of pancreatic tissue. It's just that probably won't necessarily be on your exam. So here's it continued. We're on acute pancreatitis now. Let's continue. You can see a little picture right there. A 2CK NBME question gives pancreatitis plus similar image as above, and the answer is just ERCP. For drainage of the pseudocyst within the black circle. A neurosectomy is removal of the pancreatic tissue in the setting of a high fraction of necrosis. Patients with pancreatectomy require enzyme replacement pancreolipase. Acute pancreatitis is high-yield cause of ARDS. Chronic pancreatitis. Steatorrhea in alcoholic or patient with recurrent acute pancreatitis episodes leading to results in pancreatic burnout with decrease in production of pancreatic enzymes, which leads to a decrease in proteases/lipases, which leads to malabsorption. In other words, we have normal pancreatic enzymes, that is to say, they are not elevated. Question can say alcoholic has an increase in fat and protein seen in stool. Dextroxylose or D-xylose test is normal. This is a monosaccharide that is readily absorbed by the small bowel insofar as the intestinal lining is intact. So if we get a steatorrhea plus normal D-xylose, this can be due to the pancreatic insufficiency or lactose intolerance. If D xylose test is abnormal, we know that the malabsorption is due to an intestinal lining issue such as celiac or Crohn's disease. If the USMLE gives you a CT for chronic pancreatitis, they will show you a calcification with the pancreas. The treatment of pancreatic enzyme supplementation, pancreolipase. Bile duct leak. The answer on 2CK surgery if they give you a patient with a cholecystectomy within the past week who now has fever, abdominal pain, and increase in direct bilirubin. During the surgical anastomoses created during the cholecystectomy, sometimes there can be a post-op bile leak, literally weird diagnosis, but it shows up on occasion. Sphincter of Oddi dysfunction. The answer on USMLE, if the question sounds like gallstone pancreatitis, i.e. increase in ALP, increase in direct bilirubin, and an increase in pancreatic enzymes, but the patient has not had a gallbladder for many years, so it can't be a stone causing the obstruction. You might think of something like sphincter of Oddi dysfunction. Gallstone ileus. Gallstone enters the small bowel and causes an intestinal obstruction. The answer on USMLE, if they say air in the biliary tree, pneumobilia, can be caused by cholecystoduodenal fistula, which is when a patient with cholelithiasis can develop a conduit between the gallbladder and the small bowel. It makes a little perforation and it travels through that. What the USMLE will do is give you a long rambling paragraph where they say air in the biliary tree in the last line. The answer will then just be gallstone ileus straight up, or it will be cholecystoduodenal fistula. Colodocal cyst. Asked on 2CK surgery, what they're going to do is give you a long nonsense paragraph with an increase in ALP and an increase in direct bilirubin. They say CT shows a cystic structure within the biliary tree. The answer should be a simple excision of the cyst. Students are, what's going on here? Causing colodocal cyst. So that's colodocal cyst. Yet you have time to just excise it. Ridiculous diagnosis. Take it up with NBME, not me. So again, it will have elevated ALP and elevated direct bilirubin. So you're thinking, oh, maybe it's like some sort of, whatever. So you have elevated ALP, you have elevated direct bilirubin, and they say, oh, but the CT shows a cystic structure within the biliary tree. Think about, you have to go for a simple excision of the cyst. It's kind of ridiculous, but whatever. Primary biliary cirrhosis. As mentioned above, as mentioned earlier, this will be a woman in her 20s or 50s who has generalized pruritus, elevated cholesterol, elevated ALP, elevated direct bilirubin, and history of autoimmune disease in her or a relative. Diagnose with antimitochondrial antibodies as first step, followed by liver biopsy to confirm. The initial treatment would be ursodeoxycholic acid, or ursodiol, for primary biliary cirrhosis. Okay. Spontaneous bacterial peritonitis, SBP. One of the highest yield diagnoses on 2CK, bacterial infection of the peritoneal fluid. Bacterial infection of the peritoneal fluid by mixed enteric flora. The answer on USMLE when they give you diffuse abdominal pain and fever in one of the three following scenarios. 1. Cirrhosis, 2. Recent peritoneal dialysis, and 3. Nephrotic syndrome. Shifting dullness or a fluid wave are buzzy for ascites, but questions will often omit these descriptors for stems. What they care about is you identifying when a patient either has a major risk factor for ascites or is aware of a peritoneal intervention as the cause of the presentation. In other words, they can tell you a patient has cirrhosis plus abdominal pain plus fever, where they don't have to mention is a fluid wave, but you can just have to infer, well, he or she clearly has major risk factors for ascites, so this sounds like spontaneous bacterial peritonitis. There was a 2CK question where they ask, say, a kid with minimal change disease, nephrotic syndrome, has abdominal pain plus fever, the answer should be spontaneous bacterial peritonitis. Yeah. Next best step in diagnosis is abdominal paracentesis. This refers to the aspiration of fluid from the peritoneal cavity. Do not confuse this with pericardiocentesis. Paracentesis is an answer shows up everywhere, and I've seen students avoid it because they're like, what? I thought that meant pericardiocentesis. After the paracentesis is done, USMLE wants a very specific order of what to do next. Choose white cell count and differential. First, it's listed, followed by gram stain and culture of the fluid. So again, paracentesis, number 1. Number 2, white blood cell count differential. And number 3, gram stain and culture of the fluid. So I want to read that section for you one more time, by the way, that one area. What they care about is you identifying the patient either has a major risk factor for ascites or are aware of peritoneal intervention as a cause of the paracentation. In other words, they can tell you a patient has cirrhosis plus abdominal pain plus fever where they don't have a mention of a fluid wave. But you have to just infer, well, he or she clearly has major risk factors for ascites, so this sounds like spontaneous bacterial peritonitis. Let's go back to the 3 things we talked about, the paracentesis, white blood cell count, and the gram stain. This order is important because gram stain and culture of the fluid is a correct answer in one question but wrong in another question, where the white blood cell count differential is correct to do first. The reason white cell count and differential is done first is because the spontaneous bacterial peritonitis is diagnosed when the paracentesis shows a greater than 250 white blood cells over microliters. There is a new 2CK question where they give ascites in a patient with cirrhosis, but do not mention fever or abdominal pain. However, they say paracentesis shows a 900 white blood cell count over microliter, meaning the answer is antibiotic therapy. It should be made clear, though, that the 6 out of 7 SBP questions will give abdominal pain and fever. Treatment would be ceftriaxone. Focal nodular hyperplasia. Obscure diagnosis where they tell you adult has an abdominal CT for the unrelated reason and has a 1 to 2 centimeter hepatic lesion with a central scar. There will also be a 0 mention of trauma or infection. Every student says, oh my gosh, I don't know. What the flip? I don't know. What This is a lesion of hepatocellular hyperplasia that does not require treatment. This is the answer on MBME, where they tell you CT shows hepatic lesion with the central scar. Answer is no further diagnostic studies indicated. So again, for focal nodular hyperplasia, there's no trauma, there's no infection. There's a central scar. There's a hepatic lesion with central scar when you did a CT scan. There's no infection and there's no trauma. The answer: don't do anything. No further tests. Don't treatment. Okay. I'm gonna go take a brief break again. Okay, we are back. Let's see. Okay, let's talk about high yield cirrhosis points. We're on page 124, by the way. We'll try to wrap up in 148. I suspect, though, that I'll maybe get through another maybe half hour, 45 minutes, and then retire, and then maybe go back to the third section maybe later tonight or maybe like tomorrow or something like that. But regardless, high yield cirrhosis points. Cirrhosis is a small, shrunken, burnt-out liver due to chronic disease. High yield causes are alcoholism, Hep B/Hep C, Wilson's disease, hemochromatosis, NASH, alpha-1 antitrypsin deficiency, etc. Burned out means LFTs are normal or low. That is to say, there is not transaminitis as with acute hepatitis. USMLE likes increases in PT and decreases in clotting factor synthesis in cirrhotic patients. Hyperammonemia occurs due to the decrease in urea cycle activity normally occurs in liver. This can cause hepatic encephalopathy, confusion, and asterixis, hepatic flap of the hands. USMLE likes acute exacerbations of hyperammonemia caused by GI bleeds, leading to an increase in ammonia absorption. Spontaneous bacterial peritonitis, SBP, is going to have significant increase in the high yield on 2CK, as discussed above. Esophageal varices from increase in portal pressure that backs up to the left gastric vein, discussed earlier. Caput medusa are visible periumbilical veins, superior epigastric veins. Systemic inflammatory response syndrome, SIRS. Knowing this short table is vital for understanding many IM and surgery questions on 2CK. In the setting of stress, i.e. due to trauma, surgery, autoimmune flare, infection, catecholamines and increased sympathetic activity might shift the patient's vitals out of the normal range. The reason knowing SIRS is important is because the patient can have abnormal vitals without having an infection. So SIRS, 2 or more of the following. Temp is less than 36 C or greater than 38, less than 96.8 Fahrenheit or greater than 100.4. Okay. Heart rate is, again, this is called SIRS, Systemic Inflammatory Response Syndrome. Heart rate is greater than 90, respiratory rate is greater than 20, white blood cells are less than 4,000 or greater than 12,000. He said, well, how can it be really low or really high? Well, that's the thing. It's a pathological state, right? Sepsis would have the Systemic Inflammatory Response Syndrome plus source of infection. Septic shock, sepsis plus low blood pressure. Sometimes you will see a patient's vital signs out of the normal range in the setting of trauma, surgery, or autoimmune flares, and you have to be able to say, there's no infection, that's just SIRS from sympathetic activation. Knowing if a patient is septic is important for management of patients on 2CK, where sometimes antibiotic regimens are stepped up. For example, when treating PID, pelvic inflammatory disease, by the way, if the patient is septic, intravenous ceftriaxone and azithromycin is correct on one of the 2CK NBMEs. IM ceftriaxone and oral azithromycin is wrong. This is because of the latter. The latter is for the most patients who have PID but aren't septic. Ceftriaxone is frequently an answer on 2CK for in-hospital patients who are septic from a variety of community-acquired conditions. For example, pneumonia, pyelonephritis, or prostatitis. For instance, community-acquired pneumonia is empirically treated with azithromycin on 2CK NBME 8, but if the patient is septic, we can go straight to ceftriaxone and have this is more than once on 2CK NBMEs. For hospital-acquired infections in which the patients are septic, NBME goes hard-hitting with vancomycin plus ceftazidime or cefepime. This regimen covers MRSA and Pseudomonas. So let's talk about let's see. Okay. I'm thinking about we're on 125 right now. We need to get to 148 in theory. High yield to finish the chapter. High yield referred pain. Spleen, splenic laceration leads to upper left quadrant pain, plus or minus can refer to the left shoulder. Cure sign. Diaphragm, Diaphragmatic irritation can cause pain going to the left shoulder, as on MBME. Spleen is wrong answer. The key here is that they ask irritation. Gallbladder, right upper quadrant or epigastric pain plus or minus can refer to the right shoulder. Appendix, epigastric pain initially, visceral peritoneal inflammation, then migrates to the right lower quadrant, parietal peritoneal inflammation. High-yield diagnostic modalities for internal medicine. Same as with the GI surgeries table above, we could discuss endless indications for the below modalities, but I'm staying concise here with just the highest yield points. Nasogastric tube. Insertion of nasogastric tube is the answer for the tracheoesophageal fistula and choanal discussed in high-yield pulmonary PDF. Barium swallow for suspected Zenker diverticulum shows outpouching. First step in achalasia before manometry shows bird's beak. Do not use for esophageal perforation. It can cause mediastinitis if it leaks out through a hole in the esophagus. Can be used for patients with aspiration risk since it doesn't cause pneumonitis. Gastrographin swallow, aka water-soluble contrast swallow, used for esophageal perforations because it doesn't cause mediastinitis. Do not use it if a patient has aspiration risk, causes pneumonitis, use barium instead. Esophageal manometry. Answer for achalasia after barium swallow shows bird's beak, a pressure study of the esophagus. Endoscopy, aka esophagogastroduodenoscopy. Immediately answer for any patient with new onset dysphagia and a history of GERD or heavy smoking / alcohol for esophageal cancer. Then biopsy any lesion stricture. Endoscopy plus banding for the esophageal varices emergent management. Diagnosis of hiatal hernia as on MBME, done in patients over 50 who have a H. pylori positivity on new CK form. Capsule endoscopy. Always wrong answer on USMLE. So never do capsule endoscopy. That's always the wrong answer. If you see that, don't choose it. Upper GI series. Congenital midgut volvulus in pediatrics will show a corkscrew. This is in contrast to swallow associated by x-rays to visualize the upper GI tract. Abdominal ultrasound. Cholelithiasis. First step to diagnosing cholecystitis, if negative, do a HIDA scan. First step for cholelithiasis, then do an ERCP. Intussusception diagnosis, then do an enema, definitively diagnostic and therapeutic, and then pyloric stenosis. So use it in these cases. And abdominal ultrasound is the first step you would do for both cholecystitis and choledocholithiasis. HIDA scan, answer for confirmatory diagnosis for cholecystitis, not cholelithiasis alone, if ultrasound is negative. Radio contrast is injected for the HIDA scan plus secreted into the bile. If the gallbladder lines up, there is no obstruction of the cystic duct and is negative. If the gallbladder does not light up, we know there's an obstruction by stone and it confirms cholecystitis. CT of the abdomen. Well, there's an abdominal CT. USMLE won't force you to choose, but just assume that contrast CT is always used. The only times that non-contrast CT will be an answer is for urolithiasis and intracranial bleeds. Only for urolithiasis and intracranial bleeds. Diagnosis of pancreatic cancer, highest yield indication in USMLE. Diagnosis of liver cancer and focal nodular hyperdysplasia. Renal injury, ultra high yield discussed in high yield renal PDF. Blunt force trauma to abdomen in patient who is stable. Diverticulitis. Abdominal X-ray. Used to look for bowel gas and suspected obstruction, that is to say, for example, sigmoid volvulus showing coffee bean sign. Duodenal atresia, double bubble sign. Congenital diaphragmatic hernia, bowel gas in left hemothorax. Necrotizing enterocolitis, pneumatosis intestinalis. Toxic megacolon if a patient is stable. X-rays of chest and abdomen used for duodenal ulcer perforation to look for the air under the diaphragm. ERCP, endoscopic retrograde cholangiopancreatography, type of EGD that can also enter the biliary tree, remove stones there, and inject contrast if necessary. Answer on USMLE for choledocholithiasis, including gallstone pancreatitis, after ultrasound is performed. Answer for diagnosis of cholangitis. Answer for drainage of pancreatic pseudocyst. So, answer for diagnosis of cholangitis, answer for drainage of pancreatic pseudocyst. Answer on USMLE for choledocholithiasis, after the ultrasound is performed, of course. Again, ERCP refers to endoscopic retrograde cholangiopancreatography. So the next one is MRCP, which is called magnetic resonance cholangiopancreatography. Never seen this as a correct answer on MBME, but I observe that students always pick it when they don't know what's going on, maybe because it sounds weird and specific. So if you see it, it's probably wrong. But magnetic resonance cholangiopancreatography, probably wrong if you see it. Can visualize biliary tree much more safely than ERCP, but unlike ERCP, it isn't a form of treatment. ERCP is both diagnostic and therapeutic. MRCP is purely, I think, therapeutic. It's purely diagnostic, I believe. So ERCP has that therapeutic treatment quality to it, so that's why it's useful. Endoscopic ultrasound. Never seen this as a correct answer, only as a wrong answer, which means if you see it, it's probably wrong. Can be done to diagnose pancreatic cancer if CT is negative, or to drain the pancreatic fluid collections in places of ERCP, but once again, never seen this as a correct answer. Paracentesis. Paracentesis used for spontaneous bacterial peritonitis. As mentioned earlier, those choose white blood cell count and differential before gram stain and culture fluid. Do not confuse with pericardiocentesis. So first you do paracentesis, and after that you do white blood cell count and differential, and then after that you do the gram stain with culture and fluid. That's the order you do it in. And we're talking in that case about spontaneous bacterial peritonitis. How do you deal with it? Meckel scan. Meckel scan, radio contrast uptake scan that localizes to the diverticulum at the terminal ileum. Colonoscopy, done for diagnosis of colorectal cancer, IBD, pseudomembranous colitis. Do not do in diverticulitis, can cause perforation, do CT instead. Do if patient has anal cancer prior to the excision in order to first see if there's a greater extent of cancer, might change management. Asked on 2CK form where they say there is a cancer at the anal verge and excision is wrong, and the answer is colonoscopy. Commence at the age of 45 to 50, guidelines are evolving, and then do every 10 years. USMLE will not force you into a position where the OHMG gosh. Okay. He's literally doing the way you would pronounce it. So, oh my gosh. Is it 45? Is it 45 or 50? If they where were we? USMLE will not force you into a position where you're like, oh my gosh, is it 45 or is it 50? If they force you to choose a 45 as a new guideline, it will obviously be the other answer choices are wrong. If first degree relative, parent, or sibling has colon cancer, commence at age 40 or 10 years prior to the diagnosis in that family member, whichever is earlier. In other words, never later than 40. For example, if the dad was diagnosed at 58, commence at the age of 40. If dad was diagnosed at 44, commenced at age 34. Then do every 5 years. If the patient has IBD, ulcerative colitis, or Crohn's disease, commence 8 years after the diagnosis was made, and then do every 2 to 3 years. 2CK NBME is real slick about this. They give mid-30s patient with IBD diagnosis in 20s, also has dad diagnosed with colon cancer in 50s. Wrong answer would be equals colonoscopy at age 40. Correct answer is colonoscopy now, since the patient has a IBD and should have since the patient has IBD and should have done one 8 years ago after his or her diagnosis. Patients who have a history of dysplastic polyps need repeat colonoscopies every 2 to 5 years, depending on the size and morphology of the polyps. If the patient has an HNPCC, which is Lynch syndrome, start at 20 to 25, then do every 1 to 2 years. For FAP, start age 10 to 12 and do every 1 to 2 years. I think that's familial adenomatous polyposis. Then do prophylactic proctalectomy at the age of 18 on NBME. For Poitz-Jaeger syndrome, start at age 8, then every 1 to 2 years. Okay. So basically, if you have one of these more serious conditions, you have to have it earlier on and more often. But for a normal person, you're doing it, let's say, for example, every 10 years starting at 45 to 50. But again, if you have these other kinds of conditions, it'd be a different situation. Sigmoidoscopy. Sigmoidoscopy guided insertion of rectal tube is the answer on NBME for treatment of sigmoid volvulus. I've never seen sigmoidoscopy as a diagnostic tool. I made this point because there is an alternative theoretical regimen to colon cancer screening, that is to say, sigmoidoscopy and plus barium enemas, etc., but I've never seen these assessed. Okay. Anoscopy. Shows up on newer 2CK form as an answer for diagnosis of hemorrhoids before banding is performed. This will help determine extent of the hemorrhoids, is an anoscopy. High yield polyp conditions for USMLE. So these conditions we have Lynch syndrome, hereditary non-polyposis colorectal cancer, HNPCC. Again, that's hereditary non-polyposis colorectal cancer. It's kind of a mouthful. That's why they call it Lynch syndrome, I guess. Mismatch repair genes, MSH2/6, LH1, PMS2. Mutations cause microsatellite instability. Colonic polyp/cancer are also associated with gynecologic cancer. Start colonoscopy at age 20 to 25, then do every 1 to 2 years. Familial adenomatous polyposis, or FAP. So FAP, chromosomes 5, autosomal dominant. Hundreds to thousands of polyps on colonoscopy, 100% cancer risk. Start colonoscopy at age 10 to 12 and do every 1 to 2 years. Then do a prophylactic proctalectomy at the age of 18 on NBME. FAP plus soft tissue, e.g. lipoma, bone tumors of the skull, Gardner syndrome. We have a lot of teeth in a Gardner syndrome. It's very strange. FAP plus CNS tumors equals Turcot syndrome. Poitz-Jaeger syndrome. As talked about in the start of the PDF, this combination of perioral melanosis and hematomatous colonic polyps. Start colonoscopy at age 8 and then do every 1 to 2 years. Juvenile polyposis. Shows up on 2CK NBME. Question will tell you there's a teenager, juvenile, lol, that's so funny, what? With intermittent bleeding per rectum, lol, plus colonoscopy shows scattered polyps plus biopsy shows dilated cystic mucus. I don't know what the lol is there for. With intermittent bleeding per rectum plus colonoscopy shows scattered polyps plus biopsy shows dilated cystic mucus-filled glands with abundant lamina propria and inflammatory infiltrates. The answer would be juvenile polyposis. But I guess the fact that they're a teenager might help you give it away a little bit. Only question I've seen on it, but it's on the news 2CK NBME, so I have to mention it. So it might be there when you take the exam. Hyperplastic polyps. All you need to know is that they are not precancerous and have no dysplasia. Tubulovillus. Dysplastic polyps that precede full-blown colorectal cancer are classically either tubular or villous and either pedunculated or sessile. Villous is worse than tubular, sessile is worse than pedunculated. This means that pedunculated tubular polyps are best and sessile. Villous polyps are worst. So again, tubular are the best, sessile are the worst. Sessile means flat, pedunculated means sticks out. Polyps can have mixed characteristics and hence it can be tubulovillous. True. What you need to know is USMLE will give you a random 65-year-old with a polyp plus show you a pic and plus ask you what it is. The answer would be tubular polyp. Student freaks out and says, wait, we need to know polyp pics. No. The big picture concept is that the older people who get colorectal cancer have tubular villous or tubular villous polyps, as I just stated. Wrong answers would be things like hamartomatous, juvenile, hyperplastic. You can just eliminate to get there without even knowing the image. 2CK warns you that the patient with this history of dysplastic polyps needs repeat colonoscopy every 2 to 5 years, depending on the size and morphology of the polyp. Colon cancer short points. KRAS is the answer on USMLE. Colon cancer short points. Colon cancer. KRAS is the answer on USMLE for the first gene mutated in colonic polyps, KRAS, prior to the progression to overt colon cancer. Colon cancer often develops as a result of progressive mutations rather than one mutation straight up. In other words, first KRAS, then PTEN, PTEN, and then DCC, and then TP53. You hear TP53 a lot, but it's KRAS, which is the first one that develops for colon cancer. If they tell you that colon cancer has metastasized and force you to choose a gene that's mutated, go with TP53 or P53. If they tell you a polyp is seen and there is no evidence of invasion of the stalk, choose KRAS. This reflects earlier changes in the sequence as I just wrote above. Can cause colovesicular fistulas, where there is a passageway that develops between the GI tract and the bladder, leading to UTIs and mixed enteric flora in the urine. This is also assessed for the diverticulosis on 2CK and seems to be a new diagnosis USMLE likes. This could also be done to Crohn's disease in theory, but I haven't seen it on MBMEs yet. I already discussed colon cancer screening extensively above. And I think I will take another break. I want to get a little bit further because basically we have 20 pages after this, because this is page 128 right now, and we finished about 148. So I want to get, maybe like another half hour in potentially. Okay, we are back, and hopefully this will be the last section I'll do for this video. I will probably do another reading either later today or tomorrow. Let's see. We're on page 128. We would theoretically wrap up on page 148, but I want to get another good section in, maybe 5-ish pages or something like that, so we have a little bit more breathing room, you could say. Anyway, high-yield peds GI differential diagnosis. Pyloric stenosis, forceful/projectile non-bilious vomiting in neonate days to weeks old. Obstruction is above level of duodenum, so we don't see bile. Students fixate on exact age of the kid for pyloric stenosis versus duodenal atresia. The USMLE does not care and will give variable ages. Hypertrophic pylorus, or olive-shaped mass in abdomen, is buzzy but rarely seen in questions. Ultrasound done to diagnose myotomy to treat. USMLE wants you to know that it's almost always a one-off sporadic developmental defect where the neonate will not have a broader syndrome. In contrast, duodenal atresia is usually connected to Down syndrome. But for pyloric stenosis, you will see forceful projectile non-bilious vomiting in neonate days to weeks old, because it's above the duodenum, so you don't see bile. Duodenal atresia. Bilious vomiting in neonate. Bilious equals obstruction at level of duodenum or lower, associated with Down syndrome, albeit not mandatory. Will cause double bubble sign on abdominal X-ray. Annular pancreas. Annular pancreas, another cause of duodenal obstruction with double bubble sign, but much more rare than duodenal atresia. Intussusception. Intussusception is telescoping of the bowel into itself, almost always under the age of 2. Idiopathic, but can be triggered by viral infection or rotavirus vaccination. Well, that's unfortunate. Where the mesenteric lymphadenopathy can act as a lead point for the intestinal telescoping. Underlying macula diverticulum is also a common lead point. In ultra-rare scenarios, intussusception in elderly can occur due to colon cancer. Classic presentation is intermittent colicky abdominal pain, where the kid will have episodes of drawing the legs to the chest or squatting, with blood and in the stool, plus or minus bilious vomiting. An abdominal mass, that is to say sausage-shaped mass, is a key feature, but not in all questions. Diagnosis is first done with ultrasound, which may show a sausage mass or treat sign or target sign. I've never seen NBME show the image, so they don't care after the ultrasound. The enema is both diagnostic and therapeutic. USMLE does not care what kind of enema is used. Air contrast enema is classic, but you will see all the different types of enemas as correct answers. An air enema with ultrasound is the answer on 1-2CK form. Midgut volvulus. Failure of the rotation of the proximal bowel, almost always under the age of 1. Presents similarly to intussusception, often mistaken for it, but there is no mass. Upper GI series shows corkscrew appearance. If an abdominal X-ray is performed, it will show a dilated loops, a small bowel with air fluid levels. Since we have an obstruction, treatment would be surgical. Necrotizing enterocolitis. Necrotizing bowel occurring in premature neonates born less than 32 weeks gestation presents with pneumatosis intestinalis. Air in bowel wall resembles bubbles. So this is what that looks like. That looks kind of crazy. So that's called necrotizing enterocolitis. Necrotic bowel occurring in premature neonates less than 32 weeks of gestation. Resembles bubbles. Air in bowel wall. Yep, see right there. USMLE will show you an above image in a kid born at 26 weeks gestation, and then answer is just necrotizing enterocolitis. It's not that hard. It's, to my observation, necrotizing enterocolitis usually shows up as a wrong answer choice on MBMEs, where I see students pick it in, for example, an adult, and I'm like, dude, you see that in hyperpremies. And they're like, oh, so you need to remember that it's specifically a premature neonate condition. Necrotizing enterocolitis. But what about Hirschsprung's disease? Failure of the migration of the neural crest cells direct cells distally within the colon causes an aganglionic distal segment that results in an increase in anal sphincter tone. That's normal. And then right here you have no ganglion cells area affected by the Hirschsprung's disease. Often associated with Down syndrome, presents usually as a failure to pass stool at birth as chronic constipation in an infant, depending on the severity, but do not confuse with meconium ileus, which is a term that refers to failure to pass stool at birth specifically due to the cystic fibrosis, diagnosed with anal manometry, showing an increase in anal sphincter tone, followed by biopsy. Cystic fibrosis, discussed in extensive detail in the high-yield pulmonary PDF. Just a reiteration, the meconium ileus plus exocrine pancreatic insufficiency are exceedingly high yield. Secretions within the pancreatic ducts are inspissated, meaning that the desiccated/dried up with an lumen, making them sticky. This means that enzymes can't make their way to the duodenum, leading to fat-soluble vitamin malabsorption, leading to NBME exams love vitamin E deficiency, and CF in particular presents as neuropathy. D-xylose test, dextroxylose test, is normal. Since the intestinal lining structure is intact, any malabsorption that occurs is due to the mere paucity of enzymes in the small bowel, the lack thereof, right? Recall that abnormal D-xylose test would be celiac or Crohn's disease and USMLE. So it's just an enzyme deficiency. Because of exocrine pancreatic insufficiency, not because of a lack of intestinal issue. What about biliary atresia? Biliary atresia, as discussed earlier, significantly increased direct bilirubin in a kid under the age of 6 weeks, caused by a lack of development of the intrahepatic bile ductules and biliary tree. Ultrasound will be done first, but USMLE wants liver biopsy to confirm the diagnosis. Kasai procedure is done to treat, followed by liver transplant if unsuccessful. What about autoimmune intestinal absorptive disorders? Intolerant to gluten, that is to say, for example, to gliadin proteins found in wheat, oats, rye, and barley, but not rice, causes type 4 hypersensitivity response where the T cells attack the small intestinal villi, resulting in flattening of the villi and malabsorption. The biopsy/image is past level. Below we have a normal villi on the left and flattening of the villi on the celiac on the right. Even though the disorder is T-cell mediated destruction of the villi, patients still develop antibodies which are high yield. Anti-endomysial, aka anti-gliadin, and anti-tissue transglutaminase, IgA. Patients with concurrent IgA deficiency will have a false negative results for tissue transglutaminase, IgA antibodies, since the autoimmune diseases go together, and autoimmune and immunodeficiency syndromes go together. Patients with IgA deficiency have 15 times greater likelihood of developing celiac. Celiac presents as a vague bloating/diarrhea in patients who might not be able to pinpoint what they're eating to cause the symptoms. I'd say one of the highest yield points on USMLE regarding celiac is that it can cause iron deficiency. This is because iron absorption in the duodenum is impaired from the flattened villi. For example, you might get a difficult vague vignette where you're not sure if the diagnosis is celiac or lactase deficiency, but you see that hemoglobin is low, and you're like, boom, celiac. Associated with dermatitis herpetiformis, which presents as itchy vesicular lesions on extensor areas, this causes IgA deposition as dermal papillae. So we're continuing with this whole thing on celiac right now. Dextroxylose or D-xylose test is abnormal because of the intestinal lining or architecture is abnormal, i.e. we will have flattening of villi, increased risk of gastrointestinal and T-cell lymphoma in celiac. This is called the enteropathy-associated T-cell lymphoma, or EATL. EATL. Diagnosis is made via the antibody screening, followed by duodenal biopsy as confirmatory. Treatment of celiac is simply with gluten-free diet. Lactose intolerance. Deficiency of the brush border disaccharide, i.e. aka lactase deficiency. Brush border is located at the tips of the villi. This is in contrast to the stem cells of the GI tract, which are located at the base of the crypts. USMLE asks the locations of these things. Diarrhea/bloating in response to dairy. In contrast to celiac disease, there is no iron deficiency anemia or lactose intolerance. Increased incidence in Asians, but also can develop idiopathically starting in teenage years onwards, where a young adult has a new onset of diarrhea-related condition, is usually a lactose intolerance, as lactase production can decrease with age. But once again, USMLE can trick you. So I'll be the guy to reiterate that if you see a decrease in hemoglobin, choose celiac instead. Okay. So if you see the decrease in hemoglobin, choose celiac instead of lactose intolerance. Secondary lactose intolerance can occur following a viral gastroenteritis, that is to say, for example, rotavirus or Norwalk virus. Sloughing of the tips of the villi, vignette will say that new onset diarrhea/bloating following gastro illness 1 to 2 weeks ago. This is only transient and patient will recover. This is high yield because of the lactose intolerance. Biopsy is normal. This is in contrast to the flattened villi and celiac disease. Diagnosis is made using a hydrogen breath test or detecting the decreased pH in the stool. D-xylose test is normal since the intestinal lining and architecture is intact. Treatment is with any avoidance of lactose-containing products or with lactase pills. Milk protein allergy. The biggest risk factor is not being exclusively breastfed for first 6 months of life. Will present as blood in the stool in a child who they say is, for example, 4 months old who has started on formula 3 weeks ago. Treatment is switching to hydrolyzed casein formula. Switching to soy-based formula is the wrong answer. So hydrolyzed casein formula. There is up to 50% crossover allergy cases with kids who have milk and soy protein allergy. Interesting. Vignette can say a kid was started on either a cow milk or soy formula when symptoms started. It doesn't matter, just choose hydrolyzed casein as the answer. Okay. Inflammatory bowel disease, IBD. So IBD, inflammatory bowel disease, refers to both ulcerative colitis, UC, and Crohn's disease. Both can present with bloody mucoid stools. Both are associated with the HLA-B27 pair, psoriasis, ankylosing spondylitis, IBD, and reactive arthritis. For example, if the patient has a psoriasis plus bloody stools, you say, the bloody stools are probably IBD. Or likewise, if the patient is patient with known IBD, has lower back pain, and that's worse in the morning, you say that's probably ankylosing spondylitis. Both ulcerative colitis and Crohn's disease can be associated with other autoimmune diseases unrelated to HLA-B27 like vitiligo. Both can cause anterior uveitis, non-specific findings seen in many autoimmune diseases. Both have an increased risk of colon cancer if the colon is involved, but if you are forced to choose, ulcerative colitis has an increased risk than Crohn's because the colon is always involved in ulcerative colitis, but not always in Crohn's. That's true. Yeah, necessarily UC begins at like sort of the rectal area, or like the sigmoid colon kind of region, and goes up through the rest of the colon. Both are treated with the 5-ASA NSAID compounds, mesalamine and sulfasalazine, or steroids. If they ask first treatment, go with mesalamine or sulfasalazine. Whichever they list, they won't list both over steroids. Question on 2CK IM form 8 has prednisone therapy as an answer for Crohn's disease, but 5-ASA is not listed. USMLE wants you to know that anti-TNF alpha agents like infliximab, adalimumab, and etanercept are used in IBD in patients who fail initial treatment with 5-ASAs and steroids. If they ask you for which cytokine can be anti-inflammatory for IBD, the answer would be is IL-10. Sounds weird, but just know that IL-10 and TGF-beta are more anti-inflammatory mediators. Don't worry about Th1 versus Th2 stuff. So you take 5-ASAs and steroids first, but then if that doesn't work, do something like TNF alpha agents, like infliximab, adalimumab, or etanercept if that initial treatment does not work. And also they're asking for an anti-inflammatory for IBD. Talk about IL-10, okay? Okay, let's talk about UC, ulcerative colitis. Rectum ascending, not transmural, i.e. only affects the mucosa and submucosa. This means fistula are not seen. If they say fistula to the skin overlying the anus or to any other organ, this means a transmural involvement, Crohn's. The colonoscopy will show pseudopolyps and crypt abscesses. You don't need to know what they look like. You just need to know they are ulcerative colitis. Barium enema shows a lead pipe appearance due to the loss of haustra. This detail is very important for ulcerative colitis. So here's the descending colon resembles a lead pipe. It can cause primary sclerosing cholangitis, as discussed earlier. This can be associated with the P-ANCA antibodies. Pyoderma gangrenosum is a necrotic skin lesion seen rarely in patients with UC. There is an NBME question which describes this as an ulcer with necrotic debris. Can cause toxic megacolon, which presents as SIRS, and sometimes low blood pressure in a patient with UC. They might say abdominal X-ray shows a 12 centimeter cecum, NR 3 through 8. Normal range is 3 through 8. Okay. If the patient has a normal blood pressure, NBME for 2CK1 steroids first for toxic megacolon. If the patient is unstable, go straight to laparotomy. Colectomy is sometimes performed in patients with severe UC, but very rarely in Crohn's disease. And that might just be because Crohn's disease is all over the place, so it might not be practical. What about Crohn's disease itself? So Crohn's disease, mouth to anus, i.e. can occur anywhere in the GI tract. USMLE loves giving mouth ulcers in Crohn's disease, but terminal ileum is highest yield location, terminal ileum, which is that transition from the ileum into the into the colon. So remember, the colon's anal region or rectal region is where the UC typically starts, and that's the most common area because that's where he has to start. While in Crohn's disease, the most common area is that end point of the ileum where it has to eventually transition over into the colon. So anyway, transmural, i.e. can cause an anal fistula plus to other organs. Colonoscopy shows a skip lesions where there is alternating disease versus normal bowel segments with cobblestone ulcers. And you can see those cobblestone ulcers right there. So skip lesion, left part normal plus right part inflamed and cobblestoned. Creeping fat is a buzzy term that can be seen on NBME, which refers to the intestinal fat migration that wraps around the bowel. So here's a normal intestine right here. Normal intestinal surface, normal wall. Here's a cobblestone surface, thickened wall, a big fissure right there, and a lot of this fat wrapping around it. A barium enema shows a string sign where the inflamed segments are narrowed in comparison to the normal one, as you can see right there. Biopsy shows a non-caseating granulomas, very high, non-caseating granulomas, very high yield for USMLE. You know that Crohn's disease plus sarcoidosis both have non-caseating granulomas. So non-caseating would be Crohn's disease and sarcoidosis. Sometimes associated with erythema nodosum, not specific for Crohn's disease in any regard, but tends to have an increased association, whereas UC is pyoderma gangrenosum is the association. So association here is theoretically erythema nodosum. But for UC, it would be pyoderma gangrenosum. Let's continue with Crohn's. Can cause Crohn's can cause anti-Saccharomyces cerevisiae yeast antibodies. This is on 2CK NBME, where they say that the negative for these abs, but positive for P-ANCA. So they're negative for these antibodies, but they're positive for P-ANCA, where the answer is ulcerative colitis. Intestinal malabsorption can occur, resulting in B12 deficiency, most commonly due to the terminal ileum being classic inflammatory location. Impaired fat absorption can result in an increase in calcium oxalate urolithiasis, as discussed in the high-yield renal PDF. So we're pretty close to getting up to that second hour, but I want to go do maybe, where does this end? Yeah, we'll just finish this page, I think. Irritable bowel syndrome. Don't confuse this with IBD. IBS is psychosomatic, i.e. psych-related condition. Classic vignette will be a woman in her 20s and 40s with a stress factor, who usually has alternating diarrhea/constipation. It can also present as bloating or cramping. Key details is that the symptoms are relieved with bowel motions. MBME assesses smooth muscle hypersensitivity as the answer for the mechanism for IBS. Smooth muscle hypersensitivity. Treatment for diarrhea predominant IBS is loperamide, which is an opioid that can causes constipation. USMLE will give a vignette of IBS with diarrhea, and then the answer to just mu opioid receptor agonist. Other high-yield GI motility scenarios. So here we have diabetes. Diabetic gastroparesis equals a decrease in peristalsis due to the neuropathy of the GI tract, presents as a GERD-like presentation in someone with a history of advanced diabetes. USMLE wants endoscopy first to rule out the physical obstruction. If endoscopy is negative, do gastric emptying scintigraphy, aka gastric emptying scintigraphic assay, to confirm the delayed gastric emptying. Metoclopramide is used first for treatment if it is a prokinetic agent, that is to say, for example, an increase in peristalsis, and antiemetic. It is a D2 antagonist and is also an antagonist of serotonin 5-HT3 and agonist of 5-HT4 receptors. The effects of serotonin receptors increase gut peristalsis. Erythromycin can also be used to agonize motilin receptors. The 2-week trial of PPI is a wrong answer. This is the answer for regular GERD. If the patient has GERD-like presentation with advanced diabetes, however, the diagnosis is diabetic gastroparesis, not GERD. Neuropathy to the hypogastric nerve sympathetic causes severe diarrhea. This is because of the sympathetic nerves are anti-peristalsis, so if we knock them out, we get too much peristalsis. Neuropathy to the pelvic splanchnic nerves, parasympathetic, causes severe constipation. This is because the parasympathetic nerves are pro-peristalsis, so if we knock them out, we get unopposed hypogastric. In other words, if diabetes plus diarrhea, answer would be hypogastric nerves are messed up. Diabetes plus constipation, the answer would be pelvic splanchnic nerves are messed up. So for diabetes, if you have the diarrhea on top of that, it means you have a hypogastric nerve problem. If you have diabetes but you also have a constipation on top of that means you have a pelvic splanchnic nerve problem. What about thyroid? Thyroid. Hypothyroidism can cause constipation. Hyperthyroidism can cause diarrhea. USMLE will give a vignette of a thyroid condition with a GI disturbance, and then the answer will just be motility disorder. This is the same answer for diabetes. Supplements. Iron and aluminum can cause constipation. Aluminum amount of feces. Oh, like aluminium. You get it? Supplements. Iron and aluminum can cause constipation. Okay. Magnesium can cause diarrhea. So magnesium, diarrhea, aluminum/iron can cause constipation. Drugs, verapamil causes constipation, while macrolides, orlistat, and alpha-glucosidase inhibitors like acarbose can cause diarrhea. Yeah, and I think we want to finish up on that section here. We're on page 136. We want to wrap up on page 148. So I might make another video either today or tomorrow on that. We just have that one last round of set of pages for this chapter. So if you like this video, you can like and subscribe and do all that kind of stuff. Hopefully this was of good use to you. Have a great rest of your day. Thank you and goodbye.